metal cup. It can offer a large head size, the largest head size possible, with about a 6 mm difference between the outer diameter of the acetabulum and the outer diameter of the head. It's typically HA coated or plasma sprayed. There's one version that has an anatomic laterality design with a cutout for the iliopsoas tendon, which can reduce impingement. On the downside of this is only to be used in good bone quality where you can get good primary fixation, as there's no screw fixation possible. There's also the modular dual mobility versions. These go into your standard titanium acetabular cup. This way you can put screws in. It's useful in the revision setting or in the primary setting where you're going to use screws. There's typically a cobalt chrome metal liner that engages the acetabular shell through a taper connection, although there is a new oxinium liner available, and that will give you about a 10 to 12 millimeter difference between the head and the shell diameter, so you don't get quite as large a head, but it's still a larger head than a fixed bearing. The dual mobility head typically, as mentioned before, consists of a larger diameter polyethylene outer head. The inner bearing head could be cobalt chrome or ceramic. These are snapped together on the back table, and you must ensure that they rotate freely prior to implanting it in the patient. This is a brief video showing how the inner and outer bearings work. Most of that motion, 80% is from the inner bearing, 20% is from the outer bearing. This larger ball size will give you greater jump distance and greater stability. And as Professor Haddad mentioned, numerous studies have shown that a larger head size will reduce dislocation with higher peak moments. So in shown here, the 44 millimeter head is in purple, 36 is in green. So you have higher dislocation resistant moments with the larger head sizes. What is the effect of these two bearings on wear? Well, this has been studied using the Stryker dual mobility highly cross-linked liner. They did a control group micro separation where they introduced some separation of the bearings. They introduced third body particles into the bearing, and to look at all of these effects on wear. And they did find micro separation, as would be expected, increased wear compared to the normal situation. Third body wear also increased the wear. However, they found that the highly cross-linked polyethylene had a very high tolerance for wear, not showing any sort of runaway wear, even with those adverse conditions. As mentioned before, the dual mobility has been around in Europe for over 30 years now. These are some of the original designs where it was basically an anatomic dual mobility, so you had a very large polyethylene head. Now available in the United States market, we have these anatomic versions from Biomet, Stryker, and Smith & Nephew. And we also have modular versions that fit into our standard titanium cups, our Biomet G7, Smith & Nephew R3, DePuy Pinnacle, and the Stryker Trident cups. All have modular dual mobility liners available. What have been the results with dual mobility? This is a very nice systematic review of the literature from Rush, from Craig Della Valle. He looked at 54 articles looking at the dual mobility in both primary and revision hips. For over 10,000 primary total hips, there was a 1.1% rate of intraprosthetic dislocation and a 0.5% of dislocation at the articulation. For the revision setting, they even had a lower rate of IPD or intraprosthetic dislocation and about a 2% rate of dislocation. So very good results in controlling instability in these situations. This is a paper particularly looking at revision total hip in cases of abductor deficiency, a failed constrained liner, or recurrent instability, and using a dual mobility to combat that. And they found that there was an 11% revision rate. So these are difficult cases, but none of them were for instability. This is a paper from my colleague, Jonathan Vigdorchak and Seth Jarabek. This was looking in primary hip replacements, looking at patients with high risks. So if you stratify your patients into high risk, either stiff spine, female, or high range of motion activities, they used dual mobility in these high-risk situations, and they reduced dislocation rate from 3% using a fixed bearing to 0.5% using a dual mobility. So it is a practical solution for those high-risk patients. This is a paper from the Mayo Clinic from Matt Abdel. He's looking at dual mobility versus large femoral heads in revision total hips. They compared about 150 dual mobility articulations versus 200 with a 40 millimeter head. And they found that the dislocation rate was lower in the dual mobility group, 3% versus 6% in the 40 millimeter head group. So even compared to a larger fixed bearing, it is more stable. And finally, looking at a failed constrained liner, these are difficult situations. Even using it in a failed constrained liner, a dual mobility construct could salvage some of these situations. 21% of these cases did redislocate, but 2 of them could be close reduced and they were managed conservatively. There are concerns with dual mobility. One of them is definitely intraprosthetic dislocation. This is something that is noted over time, and it's thought to occur when the outer head pops off of the inner head, and that can be happening because of wear. So you can lose the integrity of that retentive mechanism over time, and that could be because of impingement. So that's one proposed mechanism. This is a follow-up of some French implants that were over 22 years. They didn't have any dislocations at the larger bearing, but they had 4% rate of IPD. And what they found was that it was related to impingement of the neck on the retentive mechanism. So you can see here, they used a stem with a very thick neck, and this over time impinged on that polyethylene, wore it away, and with a combination of impingement and wear, they basically lost that retention mechanism, causing IPD over time. So perhaps this could be mitigated with newer designs optimizing that head-neck ratio, also with highly cross-linked polyethylene. I do want to bring to attention that there is a modern series of IPD. This is from my institution, Peter Skolko. He looked at his series of using dual mobility. He used 150 dual mobility components in high-risk cases, both primary revision and conversion. And he found that the dual mobilities had a dislocation rate of about 4.5%. But very interestingly is upon close reduction, 71% of these had IPD. And the thought is that the larger head gets caught on the acetabular rim, and then with traction on the outer head, you can see that the head is left behind in the soft tissues here. So it's very important to check after a close reduction of a dual mobility component to make sure the head is concentrically reduced. And he's even gone to the point with any dislocated dual mobility bearing, he will do it in the operating room under general or spinal anesthesia so it can be gently guided into place. I also want to bring to the attention liner corrosion. Liner corrosion is something I think that has become more, we are more aware of it, especially with the experience of metal on metal and also trunionosis. This would be corrosion occurring at that modular junction. And this has been noted with some elevation in the cobalt chromium levels in patients with these modular dual mobilities. We don't know the denominator yet, and we don't know the incidence, but it's definitely something that we should be aware of, especially in patients with a dual mobility bearing and pain. And in this study, they showed that 21% had reported cobalt levels above the normal range, and several of these had soft tissue evidence of adverse local tissue reaction. This is a retrieval study from my institution, Dr. Paget, Dr. Wright. They looked at a retrieval analysis of 60 implanted modular dual mobility liners. And you can see from these micrographs here that many of them showed evidence of corrosion and fretting. So this is definitely something to be aware of. And this is one newer implant, dual mobility by Smith and Nephew that uses an oxinium liner that may mitigate corrosion at that interface. So in conclusion, I think dual mobility is a valuable tool in the armamentarium of combating instability after your total hip replacement. In a primary total hip, if you risk stratify, it can be successful at reducing dislocation to less than 1%. It does have a proven track record in Europe with up to 15 to 20 years excellent results, and they may even be better with the highly cross-linked polyethylene. I certainly consider it in patients who have high range of motion requirements, who are at risk for instability, such as hip fractures, stiff spine, spinal deformity. I am still concerned with IPD, and beware of closed reduction attempts there. And corrosion is an ongoing concern, so definitely would consider liners that don't use cobalt chrome. The long-term results in the younger patients have yet to be seen. Thank you very much for your attention.
Dr. Su, thank you for an interesting insight into the dual mobility. Dr. Anup, you want to ask some question?
Yes, I had a great talk as usual. Do you have any indications for cemented dual mobility, especially in elderly patients who have had radiation or whose bone stock is not good, and you're worried about ingrowth of an uncemented cup? So what are your indications of a cemented dual mobility there?
Anu, that's a great point. I think there are dual mobility designs that are cemented. I've only used them in revisions where I cement them into something like a reconstruction cage. But it's an excellent point in the patient with radiation treatment, poor bone quality. As Dr. Ranawat had always said, there's still a role for a cemented acetabular component.
Yeah, we use it very often in elderly patients with poor bone stock because osteoporosis is very common in our country in elderly. So those patients who want to mobilize fast, so cemented dual mobility does a great job in that set of patients.
Yeah, and I prefer that over some other things such as a constrained liner because then the interface is protected.
Yes, that's right. Yeah.
I think we do not have studies comparing the cemented and the uncemented dual mobility cups as yet, but maybe in near future we might have those. Dr. Su, I have a question. Do you think that intraprosthetic instability after dual mobility can be managed with the isolated component poly exchange, or you would like to change the whole of the construct?
Yeah, that's a great question. I think it really points to, the etiology of why it happened. If it's kind of a one-time thing where, a patient did something extreme or there's a traumatic incident and then you have the IPD occur in the closed reduction, then I think it would be reasonable to put a new dual mobility head on there. If it's something that, the components aren't in great position, we fear that this is going to continue to happen, it's happening because of impingement, then I think you really need to get to the root of the problem. If it's also something that probably happens over time because of wear, and I haven't seen it yet because we're still doing the newer generation. If it were to happen because of wear, then I think it also is a possible candidate for component exchange.
Dr. Faris, you would like to ask something or add something to this?
No, I think sorry, I know I was unmuting. My apologies. I mean, I agree with Ed that this is something that we need to study carefully moving forward. It's increasing in use. The dual mobility currently being applied and sold worldwide is different from the traditional French data, and so I think we've got to bear those differences in mind. Having said that, it's incredibly promising. I have not been persuaded that corrosion or malseating is a problem anywhere near as big. It's a kind of theoretical rather than truly practical problem, but it's something to bear in mind. The reality, it's to remind us not to overuse it, but as a tool in our armamentarium, it's been beautifully described. It has increasing indications, and it is something that every hip surgeon needs to think about, not for every case, but for the higher risk cases.
Dr. Sharma, do you think that in India, are you, in practice, is it more the anatomic version or the modular version that's being used?
Using the modular version also. We have that, and we're using mostly dual mobility for the revision scenarios, not in the common primary cases. And what is the salvage option you have for a failed dual mobility or a recurrent dislocating dual mobility? So that's something which everyone thinks, you know, once in a while you might have dual mobility dislocating and dislocating again.
Yes. Go ahead, Faris.
Sorry, Ed. I was just going to say, that's a great question, because to me, that requires you to take a step back and think beyond the bearing. Look at the patient, look at their spine, look at their pelvis, look at the femoral position, look at the acetabular position. We've yet to hear from Dan, but I think one of the key things in my world is when there is instability, it's often more than one problem. It's not just the size of the bearing. It can be component orientation. It can be a lot of things, particularly soft tissue failure. So if, you know, dual mobility can fail everything. In fact, I think we're about to hear about constrained liners, and there's a classification system for the failure of constrained liners. You know, anything can fail. So therefore you must look at the entire system, look at all the factors in the chain. Sorry, Ed, I stepped in front of you.
No, absolutely. I agree. There's no easy solution for that. You definitely have to look for the causes. If everything were perfectly positioned and I couldn't figure out another reason for the instability, I would use a constrained liner.
Do you, when I was in HSS, there was a study going on where they were evaluating that the dual mobility might end up landing into a monoblock or a bipolar over a period of time. Is that so? Like we have in the bipolars, they act as monopolars over a period of time.
Yes, I believe they are studying the two bearings to see how they fare over time, but as far as I know, they continue to function as bipolar.
Your use of dual mobility is only select cases, or what is your percentage of in routine scene using dual mobility?
Yes, it's for me in a primary setting, it's still selected. I would say maybe 10 to 20%, not that common. In the revision, it's probably going up to 30, 40%.
So in primary, what are your clear indications where you will always do dual mobility?
So for the primary, it would be basically a lot stiff spine, sagittal deformity, spino-pelvic, where it's going to be very difficult to position that acetabular component, and sometimes neck of femur fractures.
But any reason why you don't use it routinely? Is it the cost or?
Yes, it does come down to cost. It's a more expensive construct, so I don't think everybody needs it.
We welcome Professor Daniel Berry. Dan, thank you for joining.
Happy to be here. Thanks for having me. I'm sorry I was tied up earlier. I was giving another talk here in Rochester.
No, just that's all right. We just finished a beautiful lecture by Professor Faris Haddad on prevention of instability, and
Sure.
Ed just finished about dual mobility, and we are just discussing about dual mobility. Just
Fantastic. Hi, Faris and Ed, and lots of my friends in India. Harish, I see you there. Lots of other people. Dr. Basali, good to see you.
Yeah, hi.
Ronnie,
Nice to have you back.
Good morning.
Dr. Sharma. Oh, lots of friends. Good to see you all.
thank you. Okay, what's your indication of dual mobility today? Why you don't use in every
You're
case?
talking about in the primary hip
Primary.
replacement? Yeah, so in the
Yeah.
primary, my indication is the patient whom I view at high risk for dislocation. I do a posterior approach, so I think you have to be a little more concerned about dislocation if you're a posterior approach surgeon than a DA or an anterolateral approach person. But for me, the group that I would consider using it would be the neuromuscular patient, the patient with a fused stiff spine, particularly the spine that's fused to the sacrum, patient who has a history of ankylosing spondylitis or something like that, where the super stiff spine, or a patient that I think is just super unreliable, maybe due to problems with either personality or perhaps substance use. So if somebody like that, obviously I try not to operate on them in the first place, but if you need to, I think about dual mobility. Yes, Harish.
And what I want to ask is, if the cost is not a factor to worry about, would you use dual mobility for all the patient, whatever may be the age or indication? Say you use a ceramic head on inside, and you can use the oxynium on the outside, so poly where not be much of a problem. So why not use dual mobility for all the patients? What is
Well,
the
it's a provocative question, but I'll tell you why I don't. There is the cost element that Ed mentioned, but for me, the more important element is risk. So dual mobility is not without risk. Let's be honest about that. So, yes, they're good technologies. Yes, they're powerful. But if you use a modular dual mobility implant, which in North America is the style of dual mobility implant, which is most commonly used, you have to remember that interface between the metal liner and the metal shell is at risk for taper corrosion over the years. There haven't been a lot of reports of that yet, but there have been a few, and I'm sure that over time there will be some more. Whether there's very many or not, I don't know. I'm hoping it'll be a small number, but there is that risk. Secondly, remember, dual mobilities have 3 places they can wear the polyethylene. So even though it's cross-linked polyethylene, they do have the ability to wear on the outer surface, the inner surface, and then where the head impinges necessarily against the socket to make the liner move. And that interface, the third one, is the one where there's been the most wear in the long-term retrieval studies of non-cross-linked polyethylene bearings. So I don't think you can consider them to be totally without risk. Are they at super high risk? I don't think so. It doesn't seem like that after the amount of experience we've had with them. But there are some risks, and a good total hip is a darn good operation without a dual mobility. So I don't think we should throw the baby out with the bathwater. And most patients, let's face it, if you throw out those high-risk patients and you do a good job with your surgery, your risk of dislocation, hopefully, is fairly low nowadays.
A person who is he wants to demand sporting activities. He wants to play a lot of games. So young person.
Sport is a tough one, right? Because sport is one that they could theoretically dislocate the hip, but by the same token, those are the patients that are going to super stress their hip, and the standard total hip replacement's probably got the best durability. So for me, for those patients, I try to, and frankly, most of those patients, because they've got good musculature and because they're coordinated, I don't think are at super high risk for dislocation if you do a good job of getting the parts in just the right position. So for most of those, I would prefer to do a total hip rather than dual mobility. There are rare situations with somebody's activity, like somebody whose main thing is maybe yoga or something like that, where a dual mobility might be worth it. But I don't know, maybe we should ask Ferris and Ed what they think about that question. It's a good question, really.
Dan, let me step in because you've just spoken to the exact subject we were addressing beforehand. I think it's really critical that dual mobility is not applied to everyone, not just for all the reasons that Dan has stated, but also because it really does not compensate for all the surgical errors people make. And if people believe they have a get out of jail card that they're just going to use and then abolish instability, that's not going to work. We still have to plan. We still have to get the length right. We still have to get the offset right, the soft tissue balance right. We still need as surgeons to do a good job. And using that kind of implant, it's not that nothing's for free, guys. So we need to use it selectively and monitor it carefully, but it's an exciting technology.
Yep, I agree with those comments.
Agreed. I'm with you, Dan, that somebody who wants to do impactful sports, I think a fixed bearing is better. I'm concerned about the durability of the dual mobility, the polyethylene ball over the long term.
Yeah. Let's not forget. Oops, sorry, Dan. Let's not forget, guys, it's an impingement device. So
exactly, that was my point. That third bearing where the neck hits the liner to make the liner move is impingement every single time it hits.
Yeah, so modern polys aren't that great at impinging. Old poly had better material properties for some things. So we're learning all the time.
So totally true. I never assume that just because things are good at 5 years, they'll be good at 10 or 15 or 20.
Great.
We invite Dr. Daniel Berry, our next speaker, and he'll be presenting his talk on management of instability after total hip arthroplasty. We welcome you, Dr. Berry. Thank you.
Thank you, Dr. Sharma. I will hit share screen now if you'll allow me to do that.
Yes,
and I will bring up my talk. And I will put it on presentation mode. And I will get to the start. Can everybody see the first slide okay?
Yes.
Yeah, okay.
Great. Well, a good evening to all of you in India. First of all, I wish I could be there with you. Most of you know this because I've been there many times, but it's one of my favorite places in the world to go. Most of you know I grew up there for several years of my life, and I can't wait till when travel opens up, we can get back. I hope you're getting through the COVID thing okay. I know it's been tough on India, just as it has been on many other countries. My disclosures are that I receive royalties from DePuy on some hip and knee implants, and along with some leadership disclosures that you see listed. I think that it's fair to say that hard data show that dislocation is disconcertingly common. When you ask surgeons, oftentimes they'll say, oh, I've never had a dislocation, I've only had one in my life. Well, the data belie that. Most of the time, the reality is that there are some dislocations in anyone's practice. And in the older data, the risk of dislocation within the first 90 days after total hip in the United States was 3.1% in patients over 65. It is true that the risk of dislocation has dropped somewhat, as I mentioned earlier. These are data that we published a little while ago and showed that as big femoral heads became more common, the risk of dislocation dropped. That's probably also true with modern hip surgical approaches. So both have led to a decline in the risk of dislocation, but risk of dislocation has not totally gone away. And if you look at the reasons for reoperation nowadays after hip replacement, dislocation is going to be either the top 1, 2, or 3 of those reasons, depending on the series you look at. So somewhere around a quarter of hip revisions are probably for instability. Why talk about treatment? Well, the main reason to talk about treatment is historically it has been surprisingly ineffective. And historically, the rate of success of reoperation for instability is actually worse than the rate of success for any other reoperation after total hip replacement. It's worse than the risk of reoperation, for example, for infection, even though infections are most dreaded complication. And the reason for that is that if you look at most historical series, the chances of solving an instability problem with one operation has only been between 60 and 75%. None of us would say that's a fabulous batting average in American baseball or maybe in cricket. So the modern strategy is this: find the main problems and fix them. But in addition to that, add new technologies that improve your likelihood of success depending on the gravity of the situation. Either a large diameter head, a dual mobility implant, or a constrained implant. And I will talk about the indications for each of those, at least in my hands, and try to emphasize to you the trade-off in risk and benefit between the different technologies. But first, before you start talking about those technologies, you got to solve the main problem, regardless of what technology you throw at it. So you have to know what's the main problem. And then that means that you have to know what the differential diagnosis of hip instability is. And I ask my residents this all the time, but there's really 3 main categories of problems: component malposition, some problem with the soft tissues, either laxity or deficiency, or impingement. Those are the 3 main reasons a hip comes out. But remember that in some cases, it's one of those that's predominant. In some cases, it's some sort of combination of those, all of which led to the problem that eventually led to dislocation. Let's look at each of those diagnoses for just a second individually. If the problem is hip malposition, and you can see that example on the slide at the top, which is obviously a malpositioned socket that somebody put in, the likelihood of success if you treat that with repositioning of the implants is about 80%. So pretty good odds just by itself if you reposition the implant. If the problem is poor soft tissue tension alone, the likelihood of solving that problem, if you just improve the tension, for example, well-positioned implants and you advance the greater trochanter, likelihood of success is 80 or 90%. Not bad, but again, not 100%. And if the problem is impingement, or at least that's what you thought the problem was, then the chances that you're able to successfully remove that impingement source and make the patient stable with just one operation is only around 50 or 60%. So those are the main problems. Those are the likelihood of success without added technology. So my point was earlier, and I'll re-emphasize it, that if you do a reoperation for instability and only address the obvious problems that you can see, your success rate will be somewhere between 60 and 80%. Not bad, but not as good as most of us want to do. So my strategy for this, and I think most strategy of most surgeons around the world now would be, first, solve the main problem that you can identify. So optimize implant position, soft tissue tension, and get rid of impingement, but also add some form of modern technology that gives you a better advantage. Either a large diameter fixed head, a dual mobility implant, or a constrained implant. And which one of these you use is going to depend on the specific circumstances of the patient, how dire their situation is, and how big an operation it requires to do one of these things. You got to balance all those things in revision surgery. Remember that when you think about these 3 options of added technology, there is a hierarchical ascending stability. So a large fixed head is not quite as stable as a dual mobility implant, which is not quite as stable as a constrained implant. So that hierarchy is something to keep in mind in terms of how much stability you get. But remember that that hierarchy comes with an absolutely parallel risk profile. A large diameter fixed head is pretty safe. A dual mobility implant is fairly safe, as we've just been discussing. And a constrained implant has some serious downsides, even though it has some upsides. So we'll talk about how to balance those pros and cons. Let's look first at large fixed heads. The advantage is that they give you a higher range of motion before impingement than a smaller diameter head. There's greater displacement to dislocation, so-called jump distance is greater. And the large head is partly contained by the soft tissue envelope, which makes it a little harder to dislocate. So that's why they're more stable than the small diameter head. And there's definitely a role for just changing the head to a larger diameter and maybe optimizing cut position or component position. So this is an example of a guy I took care of. He's 73, he has rheumatoid arthritis. I did his total hip 15 years before this. For the first time, he dislocated after that. And when we operated on him, all we did was change the liner. So we were able to put an elevated liner on the back, so get a little more anaversion out of his hip, and change him from a 28 millimeter head to a 40 millimeter diameter head. And he never had another dislocation. So that's sort of a good example of a patient where not doing a huge operation, keeping the cup, just changing the liner in the head was enough. Dual mobility implants have some great advantages. They have the large effective head diameter we've talked about. The dual articulation probably provides some added stability and generally favorable results, as you've all been talking about. But there are some drawbacks, which we also discussed. There's the risk of disassembly due to either wear or mechanical factors. And then if you have a modular dual mobility implant, there's the risk of corrosion between the liner and the shell. There are some strong indications for them. I would say of the different technologies that I tend to add in the unstable patient, this would be my go-to technology currently for most situations. This is a good example of a patient who I thought was a good candidate for that. This is a lady who's 60 years old. She is a chronic alcoholic. She's dislocated her hip somewhere around 50 times when I met her. We made her stop drinking, which she said she was going to do. I wasn't sure if she actually did it, but she claimed she had for a while. And then we agreed to reoperate on her. I had not done her first hip replacement, by the way, but her hip replacement I thought was in good position. So when I operated on her, I did not think that there was anything I could do to optimize the component position more. So we switched her to a dual mobility implant. You can see it's a modular dual mobility cup, well positioned, and she never had another dislocation, thankfully, at least, has not in the last 7 or 8 years since they did her surgery. Another example of a conversion to a dual mobility implant. This is a patient one of my partners that operated on twice, or 3 times actually, first for primary hip and then 2 constrained implants, both of which failed, probably due to impingement of the constrained implants. We switched her to a dual mobility implant, optimized her cup position, and she never had another episode of instability. I just saw her 3 days ago. She wants her other hip done now, 10 years after the last one, which we operated on. Constraint. When is constraint needed? There is still a role for constraint. I think that constraint is needed when you have severe abductor deficiency. Big heads and dual mobility implants are usually not enough. So that patient that you see on the bottom of my slide there with a bald greater trochanter, that patient's probably not going to be stable with a dual mobility implant or with a standard large diameter head. And then the patient who's had lots of attempts to make them stable, but you still haven't gotten them stable, sometimes you just got to throw up your hands and do a constrained implant. So I'll show a few examples of patients in whom I've done constrained implants that have worked out okay. This is an example of a patient who has proximal femoral deficiency, of course, with a tumor prosthesis, loose cup, pelvic discontinuity. So this patient ended up having a dual mobility, a constrained implant placed and a proximal femoral allograft and never had another dislocation and went on to do well. So another patient, this is the patient who had the discontinuity, but also loose cup and no greater trochanter. This patient's 90 years old. She needed an expeditious operation. We did a good-sized operation on her femur because of all the catastrophe you see there. And then we plated her acetabulum, put in a constrained implant, and she's never had another dislocation either. So 2 examples of patients with very deficient abductors in whom success was achieved with constrained implants. And then lastly, this patient who has a failed dual mobility implant. The patient's actually had 2 dual mobilities, both have failed due to instability. We felt, and she was referred to me, and we felt that the best thing to do was lock her down. So we gave her a constrained implant. Unfortunately, that has been successful. So constraint, think about the pros and cons. It's a powerful tool. You leave the operating room with the medial stability of the hip, which is a good feeling. You can solve severe soft tissue problems in a way that you can't with any other technology, but it comes at a high price. Impingement is common. There's high risk of interface stresses, and then of course there's the disassembly risk with any constrained implant. And I'll just emphasize that, showing 2 examples of failed constrained implants that of course require another operation. If you look at the success rate of constrained implants, they vary a lot from series to series. Some of that's design dependent, some of it's indications dependent, but you can say that the success rate is probably somewhere around 75%. John Callahan looked at a series of fairly successful constrained implants and found a 17% mechanical failure rate at 8 to 13 years, which he said supported the judicious use of constraint in complex cases with instability. And I think that's a very nice, succinct summary of where constraint lies for me now. So I'll conclude by saying treatment of recurrent dislocation now is a lot more successful than it used to be, partly due to our better, more methodical understanding of the multifactorial nature of the problem, and partly due to the new improved technology that we've all discussed. My last slide just says, understand the main causes of the instability problem. Solve the specific problems first, but then after you've done that, add a large head, a dual mobility implant or constraint as needed and as possible. And I would say the trend right now is dual mobility implants is the go-to device in most patients using constraint on a very careful, selected basis. Thank you very much all for your attention. I'm happy to take questions if that's what you'd like to do. And I'll stop screen sharing.
Thank you, Dr. Berry, for an excellent presentation and a detailed insight about the management of instability after total hip. Do we have any questions from the panelists? Dr. Noop, yes, please.
Yes, then excellent as usual.
Yeah, hi, Anoop. Nice to see you there. Yeah. You're hiding. I could kind of not see you in the shadows. Good to see you again, Dr. Jarani.
Yes. So then in certain challenging failed intertrochanteric cases where the trochanter is really not united, those are the cases where even a dual mobility or a constrained liner would fail. What's the Mayo Clinic experience of holding that trochanter with a plate, or what's your preferred choice of fixation of trochanter?
Yeah, it's a very good question. What do you do about the non-united trochanter? It depends a lot on how big is the piece and whether or not you have a chance to get it to heal again. In general, I would say that if the piece is big, it's not too displaced, and there's a reasonable chance I can pull it back down to good bone, I will do that. I tend to like to fix it with wires or sometimes a claw, but I don't like to use the claw plates. The claw plates, even though they give you this nice sense of stability in surgery, are incredibly devascularizing. They devascularize everything. I've not seen a very high rate of healing with most of the ones that I've seen referred to me. There are a few series that are honestly pretty favorable, but I think that maybe the surgeons really understood how to use the claw plates. Most people don't. And most of the time I see a claw plate, it's either because the patient hurts and the trochanter's escaped or because there's an infection. So I'm not wild about claw plates. If I'm going to pull the trochanter down, I tend to try to do it with wires or a claw and cables alone. And I will say that in some cases where I just don't think there's a very high chance of getting to heal at all, I honestly just leave it alone and then try to make my construct as stable as possible by getting the implants in the right position, trying to use either dual mobility or rarely constrained. So my partner, Mike Cabanello, who some of you might know, had a great quote that's worth remembering. He said, "Once the trochanter has tasted freedom, it does not like to return to captivity." And that is a good one to remember, because I think all of us who've tried to pull trochanters down have had that experience now.
So the failure of constant liner is another constant liner, isn't it? There's nothing else.
Yeah, typically, although not always, as you say. So it depends on why they keep failing. I mean, I've seen some cases where people keep going in and putting a constrained liner and a constrained liner, and it keeps failing, and it's because it's impinging someplace usually. So to me, it's not always just put another constrained liner in there. If it's failed once or twice, think about what you might do differently. Either reposition the implants and put in a constrained liner, or reposition the implants and try to go back to dual mobility. Sometimes that'll do it. And I showed you an example of where that was successful. So I think unless the abductors are totally gone, I would probably be thinking of trying to do something different usually.
What is the role of artificial ligaments and some modular adapters like the BioBall in management of instability?
I don't know about the BioBall, I'm sorry, but I will comment on the role of soft tissue reconstruction using either allograft, or some people will use things like Merceline tape or things like that. Some people have reported pretty good results with that. Bill McGann reported pretty good results of using an allograft, basically reinforcement of the posterior capsule. And so I think it is possible to do it. I think it's technically kind of hard probably to do a good job. And I think most people that try it probably wouldn't know how to do it well. I wouldn't, quite honestly. And I wouldn't have a lot of confidence that would do it. But I've seen a few cases that have been been successfully treated that way. So by others, not by myself. So can it work? I think it probably can. Is it my go-to? It's not.
Great. Before you joined, Dan, we are discussing about that intra-prosthetic dislocation of dual mobility hips.
Yeah.
Can you just exchange with the liner part rather than doing the whole revision? Have you done like that? Something.
Usually not. So most intraprosthetic dislocations occur for one of two reasons. In the modern designs, which have not had a long time to wear, usually there's some sort of either a dislocation event and then relocation, which leads to the patient having a so-called intraprosthetic dislocation, which means the liner is dislocated, or an impingement event that leads to mechanical disassembly of the device. In the patient that's had a dual mobility for 20 years, the reason is different, and that's what Mr. Haddad, talked about, which is a situation where there's been repetitive impingement against the liner, and basically the head can just kind of fall out of the dual mobility liner, and that leads to the intraprosthetic dislocations. And the late intraprosthetic dislocations usually due to wear. That one I think you could probably solve with a liner exchange. The early one, though, I think is usually due to something else, and you're probably going to have to change the position of the cup in most cases.
Okay. Well, there is a question in the YouTube that for all the faculty, in fact, how do you do your spino-pelvic assessment to decide on the type of implant for use? Dan, to start with you.
Yeah, so that's a great question. It's a sophisticated question, and as you know, there's lots of ways to assess the relative motion of the pelvis to the spine, and then try to draw conclusions about what you believe is likely to be the dynamic situation with respect to the pelvic position as patients sit and stand. There's a lot of great work that's been done on it. There's about 50 angles you can draw to try to sort that out, and most orthopedic surgeons are not able to commit most of those to memory. There are some simplifications of it that you can use that are kind of helpful. I will be honest with you and tell you that with our current technology and our current understanding of things, I don't think that I can do the sit to stand radiographs, draw all the angles, and then reliably figure out where the cup should go and then put it exactly there. So I have sort of taken a nihilistic approach that if I think it's a big enough problem where I'm thinking about doing that, I frankly will just go to a dual mobility to start with and not over intellectualize it. But I'll grant you that that's kind of an anti-intellectual approach. And I do think that eventually we'll be able to very precisely figure out how the pelvis is moving, use modern technologies, be they robotics or navigation of some sort, to precisely put the implant right where we want it. And maybe that'll be enough. But I will also say that I think we're a ways from that yet. It's a pipe dream. I think it might happen someday, but I don't think we're quite there yet, but maybe we're getting closer. I don't know, Ferris might have a different comment, or maybe Ed would have a different comment.
Yeah, Ed, what is your opinion about this? What is your current practice at present?
Yes, my current practice is the preoperative workup will be a standing lateral pelvis and a sitting lateral pelvis of the pelvis and lower spine. I'll measure sacral slope to look at the delta between those two positions. If it's less than 10 degrees, then that's the stiff spine, and I'm going to be more concerned about that, but you can address that just with a fixed bearing and changing the cup position. The really difficult one are the sagittal deformity. So posterior tilting, ankylosing spondylitis, as you mentioned, those that have tilted posteriorly, they're going to be a difficult target because they have the stiff spine and the posterior tilt. So those I'll use dual mobility.
Okay. Faris, what is your current practice at present?
So I think it's an interesting area because there are different terminologies. So I think Ed and I are pretty close on this. We look at sacral slope, and then we're basically breaking patients down into those who are stiff and those who are mobile, and then those who are anterior rotators of the pelvis and sit to stand, and those who are posterior rotators. And then we compensate on that basis. So essentially, there are some in whom you can correct and avoid impingement by changing your cup position. As you probably know, if you rotate the pelvis anteriorly, you will then close butt and retrovert, and vice versa if you posterior rotate. So you can compensate for that and look at that intraoperatively if you like. If someone is very stiff and posterior rotates, like Ed says, then there may be no solution that you can apply with a large head. And then that's when you would jump to dual mobility. So if I still think I have impingement on the software, then I'll jump to dual mobility.
Deepak,
Can I ask a question to Dr. Ferris?
yeah, let's have Deepak's opinion, what he does.
Okay.
Thanks, Shubhranshu. In my practice, fortunate, I don't have that many patients with these spinopelvic problems, but I entirely agree with Ed and Ferris that that's exactly what I would do, and I'll have very low threshold for using dual mobility for these sort of patients.
Yeah, Mrinal, over to you.
Yeah. Dr. Ferris, I wanted to know, does the robot actually help you in assessment of spinopelvic, positioning and then helping in putting in the cup when you're doing a robotic total hip?
Yes,
so does it take into account automatically, or you have to put in the data?
No, we have to put in the data. So that's where, we're not at the stage where the computer's ready to get rid of the surgeon yet. That's a long way away. Right now, we measure the sitting and standing radiographs. We look at sacral slope. We look at the change from sitting to standing, and then we can compute that intraoperatively. So you then do femur first, know your femoral version. You can then adjust your acetabular version based on enclosure, based on your spinopelvic alignment, and based on your impingement. So that has only been, however, for us for the last year. Maybe Ed and the guys in the US had access to it for a bit longer. We've only had access to that modality for the last year. Prior to that, it really was just aiming for a specific target. So the functional alignment piece is now with us. Now, has it been evaluated? Have we looked at it for long enough to understand if it changes outcome? No, but it's actually pleasing to be able to make those adjustments and look at those measurements as you go.
Thanks. Yeah.
And I've become a fan, for what it's worth, for people as a discussion point of a femur first approach. I think if you're a cementless surgeon, it's really quite interesting to understand what the version of your femur is before you do your socket. You may not change what you do, but it's good to understand it.
Let's invite Dr. Deepak now for his talk on constraint grinders.
Yeah,
we have a question.
Just one question. When you talk about femur first approach for THR, I always do acetabulum first. I don't use robo or navigation, because I think that there is only limited way in which I can put my non-cemented cup into a good quality acetabulum, like a patient with avian cases. So acetabulum is not significantly deformed. And on the femoral side, I have much more ability to change the version, the offset, the neck length. So I got much more ability to change the biomechanics of the hip, and I can dial that according to the acetabulum which I put. That was my understanding. Maybe I'm wrong. Isn't that you get more ability to change the biomechanics on the femoral side compared to the acetabular side, especially in a non-cemented hip?
So if I brought that up, I better answer that question, then the others can correct me. It will depend on the implants you're using. So if you're using a modular type of SROM or a Wagner type stem, yes, you can correct it. Or if you're using a cemented Exeter, you have a lot of flexibility. If you're using a fit and fill femoral implant or a blade, I think your ability to change version is actually pretty limited on the femur. And I have two broad advantages. One is I then understand the patient's femoral version of where the stem wants to sit. I think the flexibility there with a cementless implant is not that huge, just a few degrees, but it's really not massive. That, an Exeter cemented stem allows you much more flexibility. The other piece with a cementless implant is you can then leave the rasp in, you come back to it after you've done the socket, and you can then check if the fixation of the rasp is good, or if you need to, go a size higher, for example. So it's a good way of evaluating your femoral stem. I don't agree with you entirely about the socket. The reality is you have to have anterior coverage, and there is a set position for the socket, if you like, that maybe people like David Beveland have sold us as parallel to the transverse acetabular ligament. But by deepening, you can actually change the socket position by a good 10 degrees either way, as long as you get anterior coverage. But it does depend on what implants you use. If you use implants where you have more flexibility on the femoral side, you're probably right. So it's about your individual practice.
Shubhranshu, I apologize.
You want to add anything?
I was just going to say, I apologize. I have to take leave because I have a full clinic full of patients this morning. I was happy to be able to join you, but unfortunately it was on a day that I was already kind of booked. So I apologize for leaving you all early. I would have loved to stay for the case presentations. But thanks for having me, and I send my best to all my good friends in India.
Thank you. Thanks for joining and giving your
great to see you, Dan.
Lecture.
Yeah, good to see you too, Ed. Good to see you, Ferris, and hopefully we can all be together here before too long.
Sure.
Yeah.
Thanks, folks. Bye-bye.
Bye-bye. Yeah, Mrinal.
So Dr. Deepak, we'll be inviting you now for your talk on constraint liners.
Thank you, Mrinal, and thank you, Shubhranshu, for this very kind invitation. It is indeed my great pleasure to be associated with the Indian Arthroplasty Association and to share this platform with the eminent faculty today. Can you all see my presentation clearly?
Yeah. Sure.
Okay, excellent. Thank you very much. Okay, so I come from a place called Lancaster, which is northwest of England, very close to a beautiful Lake District in Manchester and Wrightington. And I've been here for the last 20 years or so now and practicing hip and knee arthroplasty in University Hospitals of Morecambe Bay NHS Trust. Now, Dr. Berry has got quite a few things which I wanted to cover, but I'll try in my next 10 minutes to convince you that there is some role for constraint acetabular aligner in managing the hip instability following total hip replacement. Some historical aspects. So the first reference dates back to 1956 when this was used in Moscow, Russia. It was an all metal implant, and the socket and head were manufactured together and required the surgeon to assemble this with a femoral stem. However, the popularity of the constraint implants sort of gained in the 1980s, and in the last 10 years, it has certainly become somewhat popular, not as much as the dual mobility, but still quite a few hip surgeons still use the constraint liners. So these are some of the newer implants, and as you can see, all the major implant manufacturing companies have this in their portfolio. There is very slight subtle change in the designs, but the principle remains the same. There is one implant which is becoming slightly more popular, and that is a tripolar constraint liner, where you have a bipolar head fixed in a metal, in a poly shell with a constrained liner. Now, this is a typical constraint liner, which I have been using in my practice for the last 10 years or so, and the use has been really in only indicated patients, and I'll come to that in later part of my presentation. Now, this is a typical poly liner with an extended lip, as you can see there. And the most important aspect of this constraint liner is this titanium ring, which fits into the poly liner extended lip, which prevents the deformation and also provides some constraint to the femoral head. Now, how does the constraint acetabular aligner work? I think all of you have heard now the importance of the jump distance when it exceeds 50% of the femoral head diameter dislocation of the total hip replacement arcus. So if you increase the jump distance by whatever means, you can minimize the risk of dislocation. You also heard how important the soft tissue envelope around the hip joint and the importance of the abductor muscle, particularly the posterior fibers of the gluteus medius are very, very important. And the function of the constraint acetabular aligner is akin to that of the soft tissue envelope. Now, the principal feature of constraint acetabular aligner is to capture the femoral head, and therefore, at the point of impingement, greater force is required to lever out the femoral head, and therefore it will minimize the risk of dislocation, as you can see on the right-hand side of your screen. However, the capture of the femoral head will reduce the primary arc of movement due to early impingement as well. The forces that are driving the hip movement at the point of impingement are transferred to the polyethylene capture mechanism of the femoral head. And therefore, it is very important to secure the acetabular component well in the bone, as it is very likely that these forces may then transfer to the bone prosthesis and the bone interface, make the construct vulnerable to loosening and failure. So that brings nicely to the modes of failure, which has been alluded in the previous lectures by Professor Haddad and by Dr. Berry. Now, the type 1 failure is at the interface between the acetabular component and the prosthesis. Type 2 will be the disengagement of the polyliner from the metal shell, and type 3 is a dislocation of the femoral head. Now, coming to the outcomes of the constraint liners, you have heard something already from Dr. Berry's lecture. This is a meta-analysis published by Simon Jones in Journal of Arthroplasty in 2018, where the author says that mean dislocation and/or failure rate was 11.4%. However, the data quality was insufficient for a robust meta-analysis, and that has been the problem, the scanty literature that is available with the constraint liners. Most studies were retrospective, non-consecutive, single-centered with small populations and limited follow-up period. That was a sort of a drawback of this study. However, there is a very good paper published only last couple of years in Bone and Joint Journal. This is about the tripolar constrained liners. At 10 years, the authors found the survivorship for dislocation was 95.6%. At 20 years, it was 90.6%. Certainly very encouraging and good results following a tripolar constrained liner use. This is the one which is only recently published in the Journal of Arthroplasty, where the authors concluded that the neck length was associated with lower failure rate, and there was no correlation between the large head size and the risk of dislocation. An interesting one. Now, when actually coming to the use of constrained liners, the single most or the most important factor is how you place your acetabular component. I must say the inclination should be between 40 and 55 degrees, ideally between 45 and 50 degrees, and the anteversion should be between 20 and 40 degrees, but ideally again in the 25 to 30, that sort of range. That will delay the impingement, and therefore the forces that are transmitted to the poly and the metal shell, and then the metal shell to the bone interface are slightly less. If your component position is less, again, that will make your implant last longer. Now, what are the indications of use? You've already heard by far the most common indication is inadequate soft tissues and deficient abductor mechanism. Neuromuscular disorders such as Parkinson's, post-polio, cerebral palsy, and residual weakness following stroke, and a relative indication would be poor patient compliance or people with cognitive impairment. Now, some technical tips from my own experience and some of the information that is available in the literature. You must ensure that there is a decent acetabular bone stock for secure fixation. As I just explained, the optimal position of the implant is extremely important, particularly the acetabular component. Always secure the uncemented cup with at least 2 screws. Vital. Trial the reduction using one head size smaller, and show you a small video later on why this is important, because that will prevent the damage to your poly liner. Ensure a snap fit after final reduction before the ring is fitted. Last but not the least, make sure that the ring is circumferentially fixed, and sometimes it is easy to fix it, but sometimes when you have a lot of sclerosis, a lot of fibrosis around the hip joint, this can be a little tricky. Now, I'm just going to show you a case of constrained acetabular liner failure. This is an 80-year-old female who had recurrent dislocation, started 8 years post-primary surgery. She was revised using a constrained acetabular liner. As you can see, the inclination was 50 degrees and the anteversion about 8 degrees. Unfortunately, 18 months post-reduction, she sustained first dislocation. This required open reduction. Post-open reduction, again in 6 months' time, she dislocated further. So this was the second episode of dislocation. At the time, it was decided that a further revision should be carried out. And as Dr. Mohanty was just saying, it was revised again using another constrained liner. And as you can see, as compared to the previous one, the inclination was improved to 40 degrees and anteversion was improved to 18 degrees. Unfortunately, again, in 6 months' time, this is what happened. And she ended up with a disastrous outcome of girdle arthroplasty. So again, emphasizing the importance of achieving the optimal position during your primary surgery itself. Another case, 82-year-old farmer who had a reasonably well done uncemented total hip replacement surgery, had developed recurrent instability at around 18 months. This was revised using a constrained liner. And as you can see, the position of the components alignment looks reasonably good. He had a further fall, and as you can see, he dislocated his left hip. But if you concentrate on the right hip, there is partial disengagement of the polyliner from the acetabular shell as compared to the picture in Jan 2019. EUA of the right hip was performed, and MUA of the left hip was performed. The components in the hip were found stable on the imaging, and therefore a decision was made to just keep a close eye on the hip itself. And 18 months down the line, he still has a stable hip, but remains under close observation. But this you would class this as a type 2 failure of the constrained acetabular liner. Fortunately, he still has the stable hip in place. And I'm just going to show you a brief video and photographs of a technique of the constraint acetabular technique, the case which I recently did. 86-year-old female, multiple comorbidities, had cemented total hip replacement in 2004 by hard hinge approach. And as you can see, reasonably well done hip replacement, but developed a late instability nearly 16 years down the line with multiple episodes of hip dislocation, and hip was very stable. Hip was very unstable at 40 to 50 degree of flexion and slight internal rotation. So decision was made to revise this hip, and the plan was to use in cement revision of the femoral stem, and either to use constrained acetabular liner or dual mobility for providing the stability. So when the patient was taken to theater, the hip, I usually perform all my hips by posterior approach. As you can see, the greater trochanter there, that just to give you an idea about what this picture is like. So this is the greater trochanter. So that will be somewhere there would be the femoral head, and this will be the foot end of the patient. So when the hip was exposed, there was significant disruption of the posterior structures due to multiple posterior instability, but at the same time, the abductors were partially detached. So only a small rim of abductors was attached, small tendon of abductor was attached to the trochanter. So a decision was made to proceed with constrained acetabular liner. And when you have a well-fixed cemented component, this is a technique I usually use, ream out the poly liner. And then you're left, once you ream it out, you're left with a thin shell of the poly, which comes out very easily by using some special osteotomes or cementotomes. Then you're left with the cement mantle, which is beautifully seen, and then you can carefully remove the cement mantle without actually causing any damage to the acetabulum. So this is a technique I think is most popular, and I'm sure most of you revision surgeons would be using this technique. So this patient had a nice spherical acetabular shell now. And then the next step was obviously to use a trial component. And as you will see that it was very, very stable. So there was good primary stability. And then the real implant was fixed. And in this case, I used 2 additional screws, cancel screws. The constrained polyliner was implanted or impacted. And then when you do the trial, this is obviously a cement in cement trial. The head size that is used here is 28 millimeter, whereas the size of this constrained polyliner is 32 millimeter. You certainly don't want to use the same size of the head, because you will certainly damage the polyliner, because there is very little space when you actually reduce this hip. And as you will see in the final reduction in the next few slides. So this is actually the final reduction. As you will see now, you will hear a pop, or there is a pop when the hip reduces. So that is the pop there, and that means that the head has nicely been snapped into the constrained liner. The next step is obviously you have to fix the ring, and always ensure that this ring is circumferentially fixed onto the polyliner. Sometimes it is easier said than done. There is a special device you can get to make sure that the ring is circumferentially fixed. Now, you will see in this short video again the stability. So the hip was moved into 90 degree of flexion, and it was very stable in both 20 degree of adduction or adduction and about 20-30 degree of internal rotation. So fairly good stability you achieve intraoperatively. These are the 2 last intraoperative pictures. So the next thing which you have heard from all the speakers, that it is important to ensure that the soft tissues are well respected, and you secure these soft tissues onto the bone as and when it is possible. So in this case, the abductors were secured using 2 bony anchors, and posterior structures were repaired using the transosseous sutures. So this was the final photograph. We achieved 40 degree of inclination and about 25 degree of anteversion, slightly more anteversion. But as I mentioned, you will get away with slightly more anteversion, especially when you are using the constrained liners. It is very important this position is achieved, good inclination and good anteversion, to achieve a good outcome following a constrained liner use. Another case, a post PFR, proximal femur replacement recurrent dislocation. Initially, the cemented cup was used. This was revised to a constrained liner. and good follow-up at 2 years. Again, the main element here was soft tissue, which was the reason why the constraint liner was used. Another case where you can see, this is a case, just ignore the extrusion of cement on the femoral side. This was a case where this was a revision carried out in 2002, but the patient started developing instability in 2015. As you can see, there is no greater trochanter. The greater trochanter is already detached, and the decision was made to revise this instability using a constraint liner, and a very good outcome at around 2 years. No further dislocations. Conservative hip revision, but it works well. 81-year-old male, skirted head use, dislocation, and 6-year follow-up with constraint liner without any problem. So coming to my final slide, take-home message. There is a definite role for constraint stable liners, hip instability for right indication. Its implantation should be considered when all other factors have been optimized, especially the component malposition. Again, very, very important. I can't emphasize more than this. Good acetabular bone stock essential for stable implant fixation. It is again very, very important that you have a very good bone stock and your fixation is very secure because of the bone and the prosthesis interfaces produced by the impingement. Use cautiously in young and high demand patients. I would rather say that consider using dual mobility if you can. In our practice, it is the implant of choice for PFR to provide a stable hip. It has definitely a role in the management of instability, but it's got to be used very, very cautiously as the consequences can be disastrous. I know that dual mobility is getting more and more popular, but I certainly feel this has a place in the management of instability. Thank you very much, and happy to take any questions.
For an excellent presentation on constraint liners, and we have all used them once in a while in our practice. Should I ask you a question like, would you agree to disagree that dual mobility has taken over the constraint liners? And I haven't seen now, I haven't used and I haven't seen people using constraint liners for a long time now. So I don't know how it is in UK and with the other colleagues of mine from the IAA panel.
I mean, I'll start and then I'll let the other panelists to answer as well. In UK, certainly it is being used, and I have been using it for the last 10 years. And in my practice, I use it almost exclusively for revision scenarios. I have used only once in a case of neuromuscular disorder, the constraint liners, but I completely agree dual mobility is becoming more and more popular. Certainly, it is not the case in the entire UK as of now, but its use has certainly increased.
Dr. What's your indication for cemented constraint liner? Like in elderly population, where you showed us one case with the revision, the implant bone interface was not good, and then it dislocated, or the whole of the implant was dislocated. So do you think that the cemented constraint liners could be a good option in these cases?
Well, it's a very, very good question, whether you can use a cemented constraint liners or not. But the most important factor remains is the position of your vestibular component. Why that he failed is because I showed you the anteversion was only 8 degrees. So there was impingement which was continuously occurring on hip flexion, and therefore it failed. So if you want to use a cemented constraint liner, again, the most important thing is you should have a good position. I have to say, I haven't used cemented constraint liners, and I really am a bit skeptical about using the cemented constraint liner in my practice.
It's a good bailout in very elderly population with dislocating hips. We have used in some patients, and then these patients who had a relatively lesser lifespan, probably a cemented liner has worked very well in my practice.
I completely agree. There is definitely a place for cemented constraint liner as well, but it's certainly in my practice I haven't got that luxury of having the cemented constraint liner on shelf, so I use what is being available to me. Thank you.
Paris, what is your opinion about that?
Cemented, the only time I use a cemented constraint is in a high-risk abductor deficiency case where I've already got an ingrown socket, and then I will cement within that socket. And in those cases, you have to make sure you have a roughened interface and you have it well covered. Otherwise, it will debond pretty quickly. So I don't have an indication in my practice for a cemented constrained liner otherwise. But I have to say, I'm in that camp where you have to have multiple risk factors and soft tissue failure to get a constrained liner. The other thing people never talk about with a constrained liner is the range of motion of that hip is awful. You know, that's what it's designed to do. So if people suddenly think they put it in a young patient, then actually that patient's function is severely compromised. It's really got a lousy range. So, 15, 20 years ago, constrained liners were the bailout. I think now the standard is dual mobility, and you've got to very selectively use constrained liners. And if you are going to, you've got to get really good fixation, ischial screws as well as the superior screws, and hold those patients back for a while because the interface stresses can threaten your ingrowth.
Ed,
Yeah.
I would ask a question to Ed. The case which Deepak showed that there was a pull out of the constant liner along with the cup and there was an osteoporotic bone. Is there a role of cemented, dual mobility hip in that case when the bone quality is poor?
It certainly could be. I think that I'm not that familiar with cementing it directly into bone. As I mentioned, I usually cement it into a shell that's well fixed already. As I've already mentioned, I do have some reservation about using a constrained liner in basically an ingrown shell, just because of the forces placed upon it. So very often I will talk to a patient. I'll use a system that has both the dual mobility and a constrained, and I'll start with the dual mobility and I'll say, well, we'll go with the dual mobility first, get ingrowth, and if it's stable, it's great. But if necessary, if you do dislocate a dual mobility, then I have the option of a constrained later on down the road.
Any other questions regarding constant liner? That was a beautiful lecture about everything about constant liner. Or else,
so should we go ahead with the case presentations now, Dr. Mohanty?
Yeah, sure.
So I'd like to invite Dr. Pradeep Bhosle to present his case on a recurrent dislocating hip and how he has managed that. Dr. Pradeep, welcome.
Yeah, thank you very much. This is one interesting case. You can call it as an extra articular deformity in rotation. So, as you know, recurrent dislocation is very common, second to aseptic loosening. And once it dislocates, there is a very high incidence of redislocation. Most of the dislocation occurs in the early month post-operatively, within first month, 70%. And once it is a recurrent dislocation diagnosed, then surgery is the only option. So this is an interesting case. 35-year-old male, he was operated outside 7 months ago for avian hip replacement cemented has been done by anterior exposure and old Chanless 22 head monoblock conventional poly, and we have confirmed it is aseptic. And 4 attempts of reduction tried, to surgical open reduction and to close reduction with even plaster spica. And it was subsequently dislocated and left it like this. He was walking like this and ultimately came to us. And he had a history of plating done 6 years ago. And there was a malunion of rotational deformity, external rotation deformity. And preoperative planning, it was painful, shortening, and this was an inclination of the acetabulum 52. So 18 degree of malunion of the femur in external rotation. It was treated 6 years ago. Cement, it was well fixed cemented stem, socket inclination was 52, anteversion of 28. Distal medullary cement was extending right up to the femur, lower third, and there was a plate. And on CT, we saw 55 degree of anteversion. So this was a problem. On normal side, there was a 14 degree of anteversion, while there's a 55 degree of anteversion. So this was the main problem. So this was the etiology of the dislocation. Socket inclination 52, femur anteversion 55, small head, probably poor soft tissue balance. Once it dislocates, the soft tissues are become lax, and anterior exposure, probably they could not judge the version correctly, and they missed the malunion external rotation. So this was a well cemented and cement going right down. So there's no chance of using ETO or cementless stem. And so preoperative planning, you can see so much of anteversion. So femur anteversion error, the normal anteversion is 14 degree and malunion 18 degree. So for extra-articular, you have to add 32, and there was an error of extra anteversion. So posterior exposure, one biggest advantage is the leg is the best guide for giving a anteversion, which is not possible with supine position. So this is the leg position. So any amount of malrotation can be easily adjusted with this position. So you can give a corrective anteversion. And this is what we did. We removed the plate and everything was stable with good anteversion. So we strongly propose that posterior exposure, this is one added advantage. Vertical leg gives any amount of malrotation, you can put a correct anteversion. And this is 12-year follow-up. Very happy. And these are the various options as it was discussed. Thank you very much.
Thank you, Dr. Pradeep. Any questions we have regarding the case? Dr. Rajiv Sharma, sir.
Yeah, I think it's very well done, Pradeep. It's the right indication in the right way.
So basically, extra articular deformity is also there in the hip. So rotation can be corrected at hip level. So only
Ferris was mentioning,
deformity. Yes.
Dr. Ferris was mentioning the degree of rotational deformity that is acceptable and that can be corrected. Can you tell us about that, Dr. Ferris?
So I think typically about 30 degrees you can correct, but it depends on what type of implant you're using. You know, we've all got DDH experience. I'm sure you all have, of being able to use an SROM type stem or being able to use a Wagner type stem and correct to a certain extent. For me, certainly in a DDH scenario, I'd be looking up to about 30 degrees. I can correct beyond that. I'd do a rotational osteotomy, particularly if we're doing a shortening osteotomy for those difficult cases. So I think it's about, I mean, this is an interesting case and there are a number of ways of solving all these difficult problems, but I don't think there is a set number that you can go on, but that was a sort of from my experience.
The beauty of cement is that you can adjust the certain amount of rotation, and in this particular case, when the cement was extending down the canal, and probably this was the best option to do. Deepak, what is your opinion about this case?
I think very well done. I would have done exactly the same. And it's you did the cement in cement revision, isn't it?
Yes, yes.
And that is a really good thing to do. To take that degree of cement out from the bone is absolutely
impossible.
It's almost impossible to without damaging the femur. So I think really well done, and that's what I would have done. Excellent.
Thank you. Let's move on to the next case.
Next case. I'll invite Dr. Rajiv. A dislocating dysplastic hip. That's what he's going to present. How is managed that case.
Thank you, Mrinal. Thank you, Shubhranshu. It's a wonderfully presented dislocating hip and the options for the treatment. What I am going to show here is a dislocating hip in a dysplastic arthroplasty. Now, dysplastic arthroplasty is quite commonly done in our country now, mainly owing to the medical tourism. Now, present you one who had a surgery. Now, this patient who was a 57-year-old lady with a proximally migrated arthritic hip. And this looks like a typical patient that we get of the dysplastic hip with the severe arthritis, the patient limping, and severe contracture of the tissues proximally. Now, what the surgeon has done here is that this shattered proximal femur. And why the shattering of the proximal femur is, just for the record, that when the surgeon is not able to reduce and he tries to forcefully reduce it, and in that process, if he doesn't follow the subtrochanteric osteotomy at the right time, now this kind of a problem can happen, as we see here. And we see here that the tip of the trochanter is migrated proximally. So this patient had been having the dislocation of the hip for quite some time before she reached me. And we see here, if we assess, the acetabulum is seems to be well fixed. The proximal femur is all shattered. The dislocation is obvious. We see very few parts of the bone here which probably have absorbed back because of the patient has been walking on this dislocated hip. So with this problem, when we started working out the patient, we could see that the shattered proximal femur, we could see the dislocation. But what we must always see in these patients is the possibility of infection. And when the aspiration was done from this patient, and this, seeing that CRP and ESR were raised, and that showed the growth of the MRSA. And this possibility should always be seen and imagined in any revision scenario. That's what we practice as a routine. And that's how this patient, obviously, we treated her with the 2-stage revision. When we word about how these implants were removed. Now, the femoral implant was the most difficult to be removed because the distal part here was fixed very, very well. And it took us maximum time in removing this. The cup removal was still easier. And then we preferred a cemented implant with the extra antibiotic cement applied here proximally. And I did use the long cemented stem because it was impossible to fix it otherwise. And we see here that this all is the cement. It is not the bone, it is the antibiotic cement here. That's what we see here with time. And then after, in the second stage, we removed the cement block and we did the cementless constrained liner along with the tumor prosthesis. And we see here at 3 months, this patient walking with the help of a stick. At 3 months, patient is able to do the reasonable good function. At 3 years, we said the cup is very well taken up by the bone. Proximally, we see that a lot of this bone is trying to hold it in its position. We try to suture back the as much of abductors as much were available. The fixation distally in the bone was good. This stem was 10 millimeter, and we must say that less than 10 millimeter stem is a problem, because that less than 10 millimeter stem can have a fracture, mostly at this point. We've had in 2 of our patients of tumor prosthesis. That's what we see at 3 years. And it was very rightly said in the discussion that these constrained liners, too much of movement is not expected. It should not be done, but it should be, the position of the cup should be seen very well. It should allow the patient to at least sit on the chair or a reasonably a lower stool very well. So what is important in these patients is that any revision the possibility of infection should always remain in mind. Abductor mechanism is very important, and whichever, whether you are using a constrained liner or a dual mobility cup, probably the abductor mechanism should be sutured very well in the patients. Dual mobile liner could be an option, probably not in this kind of a situation, but in most other situations, you use the dual mobility. Constrained liner is a good rescue, and we must remember that when we are using a mega prosthesis or such a major surgery, the infection rate could be very high. Thank you very much.
Thank you, Dr. Raji, for an excellent case and an excellent outcome. The case is open for discussion among the panel.
Rajiv, metal ring in that constant liner appears to be a little more away. Is it still in place, or it is?
I think that this is because of the X-ray position. The ring will always look far away from the cup, and that's what normally situation. But this is not a displaced rim. It is a very well placed rim on the cup.
Probably this acetabulum is the not the totally hemispherical one. This is 160-degree cup, probably Duralock or something.
Yes.
And the medial bone is ectopic bone, or?
These are the remnants of the bone which were present during the shattering. So we could suture back some of it, but obviously some of it was not approachable.
Yeah.
Dr. Sharma, that's a wonderful result. I think you gave a very good message also that we must always be aware of infection as well. So that's a tremendous clinical result. And I agree with you, even though I'm the dual mobility proponent here, this is a case when you don't have the abductors or very limited abductor function, I would have used a constrained liner as well. So kudos to you.
Thank you so much.
Great.
Do you want to add something?
Yeah, I think it was a really challenging case, I have to say, and the result is amazing, I have to say. I hope you don't have to go into that hip again ever in your life, because a further failure means a total femur replacement, which is never an easy option. But I think given what the case started off with, you achieved a fantastic outcome. And constrained liner was absolutely right for this case. Completely agree.
Thank you so much.
Thank you, Rajiv. Do you mind sharing your screen?
Yes.
Right, Dr. Harish now to present his case on recurrent dislocations after multiple revisions. We welcome you, Dr. Harish.
Hi, Dr. Mohanty, I apologize that I do have to sign off. So it's
Okay.
been such a pleasure being part of this with everyone.
Thank you,
Dr.
Indian Arthroplasty Association. I extend your gratitude for joining.
Thank you so much.
Thank you, Dr. Su. Okay, it's a case of multiple dislocation for which multiple time revision surgery was done, and then we had to salvage that procedure. This was a 24-year-old young male had a motorbike accident and pelvic acetabular complex injury. You can see that there is a diastasis of the symphysis pubis, the entire hemipelvis is shifted up, and there is a central fracture dislocation of acetabulum. So it was quite a major injury. It was referred to a central institution for further management by the orthopedic surgeon who saw the patient first. And I think that was the right thing to do, because these cases require a specialized unit, special experience, and a bigger medical backup. But somehow this was how the thing was fixed. And you can see that the surgeon has initially used just a figure of 8 wire for the symphysis and tried to put some transfer screws to fix it. There was no posterior fixation done. And then they tried to do a posterior fixation by second approach, by the posterior approach. This was the anterior approach. You can see that the staples which were seen. And beyond that, the patient had a significant pain, and there was infection, and then they had to remove a lot of things. Multiple debridement happened. And eventually, because of severe infection, the entire head, which was partly absorbed, was removed. And the patient was left with a condition like this. There was an antibiotic cement spacer, and patient was given a long-term antibiotic. And then after stopping antibiotic almost for a year, patient was advised a revision surgery to put an implant. Now, This surgery was done. I don't have all the x-rays because they are the x-rays kept by the parent institution. It was done initially with a tantalum revision cup apparently and a non-cemented stem. And following the surgery, apparently there was a dislocation, not once but multiple times. And eventually the surgeon couple of times did open reduction. It wouldn't work very well and had to re-revise the surgery. And they used an acetabular cage along with a cemented cup. And this cage was kept on the top of the tantalum cup, which was put inside. They didn't try to remove the tantalum cup. The cage was kept on the top of the old tantalum cup. And then they use a long stem solution stem. They revised the femoral component, use a long stem solution, which is a fully porous coated long stem device. And the incidence of dislocation continued. I mean, it never stopped with that. So they eventually used a constrained liner, and which was fixed directly on a cemented cage, which was put inside. Again, the dislocation didn't stop. It continued to dislocate, and eventually that hip with a constrained liner around the neck got auto adjusted in some location in a soft tissue bone mass. Patient, I think, was tired of multiple surgery. He must have undergone, according to his count, about 12 to 13 surgeries by now. And he was walking with a walker. He actually was an engineer. He's a young guy, 25-year-old. And the surgery started from the time he was 22-year-old. So about 3 to 4 years, he was undergoing all this process. Ultimately, he got tired and he was walking with crutches, both sides, and continued with his job for next 2 to 3 years. And then somehow that became very painful. Walking on a crutches and limping become painful, started getting back pain. And this is how I actually inherited the patient. So this already has undergone about 12, 13 surgeries. Multiple scars could be seen on the side. And you can see that there is a tantalum cup. There is a broken cage, which was something like a Berg-Schneider cage on the top with a fragmented hip. And you can see the head, which is also dislocated in some weird position with a ring around the neck, indicating the worn out, probably now the constrained design. And the surgeon has already done a couple of times the trochanteric slide, trochanteric repositioning, apparently to improve the position of the implant. So this is a lateral view of the same picture. The head is dislocated. You can see that a trochanter proximally is totally mishappened. It is completely distorted. It is gone completely anteriorly, and we had to decide what to do about it. Now, question is, how do you plan the revision in this case? Should you use a constrained device again? Should you go for a large ball or tripolar component? What is very important, I want to show is that many times looking at the X-ray, you get completely flummox and you feel that, oh God, that is very difficult thing. Very rarely we do analyze the actual CT scan. And that's why if you do the CT scan assessment and you can understand exactly where you can put your component. Now, if you can see in this X-ray, the symphysis distraction is completely healed by now somehow. And there is a bony mass forming the dislocated proximal part and distal part of the pelvis. So the pelvis is probably healed, but in a malunited position. The anterior column is completely shifted medial and a posterior column is reasonably intact. So when we took the CT scan, you have to see that these are the 6 pictures. These are from the front to back, as you go from number 1, 2, 3, 4, 5, 6. Look at the first picture. That is the anteriormost picture. It's a coronal plane, and you can see that the cup is completely seen. You can see a portion of iliac crest, and as you go behind from 2nd, 3rd, 4th, 5th picture, on the picture 5 and picture 6, you can see a proper posterior part of the superior pubic iliac wing, and you can see there is an adequate amount of bone in that area. Now here you can see that we are gone actually behind the cup. So technically the surgeon has put the cup entirely in the anterior column, entirely leaving the posterior column of the pelvis intact. So initially the cup position was completely wrong, and that may be one of the reasons why it was dislocating all the time. And if you see the transverse section, again you can see that if you go from the top to bottom, from the left to right, and as you go on the lower and lower thing, these are the pictures. You can see that these are where the cup is actually getting finished. These are the inferior pictures, and you can see that there is a medial wall, and you can see there is a triangular column of anterior and posterior column here. If you can see in a bigger picture close up, this is the lower end of the cup. You can see a portion of the cup. You can see portion of the tantalum cup and portion of a cage which is broken. But what is important to see is this is actually where you can put your revision cup. This actually entire area is kept virgin by the surgeon. It has not reached the position where the acetabulum should have been. And if you put a cup in that position, probably you can get a reasonably good support on the posterior wall and a posterior column and a superior column. Also, there is some element of component support in a part of an anterior column which is there. And in a coronal plane, the cup could come somewhere here. We may have to use a little large cup so that you can get a superior hold. So looking at this picture, I was thinking probably I can get a primary cup position in that, although we had kept the revision cup and revision implant ready. So this is on table picture. You can see that there is a significant deformity of the trochanter. We went by what I call a stent approach, where we go by front and back, both exposure. And if you can see in this exposure, the trochanter and the femur, which was positioned, was completely wrong. The surgeon has kept the implant is significantly anteriorly tilted. It was significantly anteverted implant and retroverted cup. So they was trying to match the cup to the stem. And you can see that in the screen, when you rotate the cup, this hip is going to get dislocated because the orientation of cup and orientation of the femur, both of them are not completely right. That's a lateral view, and you can see that the orientation is not very good. We had to then revise the stem also, which was the long stem cemented. So to get the stem out, I had to do trochanteric osteotomy, get the trochanter out, and then expose the cup. Now, we could expose the deeper tantalum cup, remove the stem, remove the screws, and when the cup was out completely, there was just close to the cup, the anterior femoral vessels and femoral, you can see the femoral nerve very close to that. And we were very lucky that we didn't damage it. There was a soft tissue in between that. And when we was washing, we could actually identify that it was so close to it. You can see that position very close to the anterior part of the femur. And the posterior part of this is the amount of bone and all the rubbish and necrotic thing, because there was a lot of metallosis which happened because now the head was rubbing against all the broken metal pieces. You can see that behind it, there was enough bone stock, and that bone stock could be rimmed, and we could actually rim in that area which was much behind the primarily put cup by the primary surgeon. And we could actually get a good primary fit of the revision cup. We had gone for about 52 size cup, not a very large cup there. And you can see that the exposed femoral nerve was much anterior, which was below the original cup, which was put by the initial surgeon. So this is the area where we went as we planned according to our CT scan. Then after putting the cup, we put this is the revision cup where there are peripheral screws which can be put. We put the constraint, we put a standard liner, and we have to revise the entire femoral stem. Now, revising a well-grown, a long, non-cemented stem is not an easy job because it's very difficult. It's very easy to say we can split the femur and go by a flexible osteotome. But eventually, you try to go around it, it end up splitting the entire femur. And what I had in my hand was these multiple pieces of proximal femur, which were along with the soft tissue attachment. And only then I could remove this implant. So this is a picture when the femoral cup or femoral stem was out. So we then use a longer stem femoral non-cemented. We wired up all these proximal fragments along with the stem. We use a longer solution stem, and entire proximal soft tissues were wired along with the hole which is there and the proximal end of the solution stem. So we could get the trochanter back on the femoral component. Now, all this allowed us to get a good orientation of cup as well as good orientation of the femoral stem. This patient was kept in a plaster boot for some time for the soft tissues to heal post-surgery. This was a picture after the end of operation. This is a 4-year post-op results. The patient has healed very well. He has formed some amount of myositis along the abductors, but I think that's a good thing because that will prevent the redislocation. This patient is now walking very well. He traveled by public transport in Bombay, and that's a feat in itself. And if you can see him walking, amount of limping is significantly less, and he has got a much less tendon and bump. You can see that when he stands on one leg, the pelvis in that side, opposite side, can be lifted up. So it's not sagging of a pelvis when he tries to stand on the operated leg. So this happened probably because we could restore the trochanter back on the femur and get the abductor stability back to the patient. So it's about 4 years. So far, he has done very well. He hasn't dislocated. He is now planning to go abroad. He's planning to immigrate to Canada probably, because he's, I think, fed up of Indian job scenario, but that has stopped because of Corona. So the point is, when you try to do revisions for dislocation, as it was mentioned in a couple of lectures in the morning, we must find out the cause for revision and find out exactly how we can realign the whole thing. It is not necessary that you have to look for a constrained design, or you have to look for a modular tri-component, like because those are the soft options. If you can get your alignment proper, if you can get the soft tissue back, you can probably get a very good outcome and solve quite difficult problem with relatively simple solutions. Thank you.
Thank you, Harish. That was an excellent case that one need to understand, as Dan told, that you have to understand the biomechanics and the bone stock and cause, and you can get away with putting a primary hip in such a complex situation. Faris, your suggestions, comments, views?
No, I mean, I think the last two cases illustrate very nicely the importance of planning and getting it right the first time, because what you were doing in both cases is salvaging some really horrible situations from people not necessarily thinking through the first operation and then compounding that again and again and again. So it's a wonderful rescue. It's, it is remarkable that you got away with such a simple socket in such a difficult case. Well done.
Thank you. Deepak, any suggestions?
No, I think I'm just lucky that I don't see these sort of patients in UK. I'm very pleased to see the outcomes. It's just unbelievable, some of the things that you guys have shown today. But the most important thing here is planning. But the use of CT scan, which is so vital in assessing the situations and diagnosing the problem, is very important. That is well emphasized in this case as well as the previous case. Unbelievable. I don't have words. It's really good outcome.
Thank you.
Anish, I think one thing that you showed very well, that when you remove a well-fixed femur at the stem, the possibility of combination proximally is very, very high. And I think that is the point which we all should remember.
It's not a so easy thing to do, though. Many times,
right? Yeah. Whatever kind of a osteotomy, trochanteric osteotomy, extended trochanteric osteotomy you do, but I think that you are very right that it's very difficult. And you very rightly delineated that how the posterior part of the bone was intact to place the acetabular cup. I think it's very well done.
Great presentation, Dr. Harish. And I think we will invite Dr. Anup Jorani for his presentation on role of soft tissue flaps in prevention of dislocation in total hip arthroplasty. Dr. Anup, are we ready with your presentation?
Can you see my screen, please?
Yes, yes.
All right. So my case is a little counterintuitive because unlike orthopedic surgeons, I'll be talking of soft tissues. And we have seen that by reflex, we try and manage everything by implants and more implants. So let's see if we can do some soft tissue work as well. So this is a case, 30-year-old male, history of CVA right side, ICU admission 3 years back. You can see a matured heterotrophic ossification. He's got a fixed flexion deformity of 30 degrees, which is obvious on the pelvis X-ray on the obturator foramen. This patient has a limp, can't walk. Neurologically, he's okay. He doesn't have much muscle weakness on this side. He's recovered from the neurology point of view. We have a go ahead for surgery, and he's wanting surgery obviously because of lack of movement and spinal pain because of a fusion, bone-to-bone fusion, because of the heterotrophic ossification that you see there. It's important to see the CT angio to see if the HO is impinging on the vessels, though X-ray gives quite a clear picture of what's going on. We should see all the CT films, the coronals, the axials, and the SAG. More important, the axials, and you can see that the HO mass is not anterior. So we really don't need a CT angio, but as a workup for all HO cases, we do a CT angio. But here you can see that all the HO mass is truly on the posterior column there. And into the abductors. There you can see a 3D reconstruction. You can see that the abductors are truly a ossified mass now. So the G medius and the G minimus there you can see is an ossified mass. And when we go into expose, we'll truly need to excise all that bone to expose the hip and to move it and do a total hip replacement. So there you can see, we should also see the sciatic nerve or the proximity of the sciatic nerve to the abductor mass, because when the abductor mass is ossified, the sciatic nerve will be very close to it, and we'll need to start dissecting the sciatic nerve distally. Visualize it to under this ossified mass, then I go for the excision of the ossified mass. And you can see there that the abductors are, that HO written here is actually the abductor. So the G medius and part of the G minimus is completely ossified, and you don't have a single muscle fiber there. So you need to take everything out and then expose the hip. So you can see that's the kind of HO mass that was excised. The sciatic nerve was dissected first distally to proximally to ensure that it's out of harm's way. There it is. So this is a ball trochanter completely. The mass is excised, the hip is exposed. I did a total hip replacement with a dual mobility cup to prevent instability. This is a young man. And more important, I think, is the soft tissue reconstruction. And is indicated in these cases is a G-max flap. And let's focus on how to do a gluteus maximus flap where there is complete absence of the gluteus medius plus minus minimus in HO cases or revision situations, which predisposes the hip to instability. And we cannot solve these problems just by using more and more constraint, but we should do soft tissue reconstruction. Now, there are two parts of this flap. The first is the posterior part of the flap, which you raise from the part of G max, which inserts on the fascia lata. So there you take it off, you can see there, you can see the sciatic nerve, which is under the methylene blue mark, and you take it as a flap with the part of the tensor fascia lata, and that's the posterior part of the flap, taking great care of the sciatic nerve. Next is the anterior part of the flap. This part of the G max, the fibers are more oriented towards the femur, and it's supplied by the inferior gluteal nerve. And this is the anterior part of the flap is likely to, more likely to overtake the function of G medius because of the same nerve supply and the same direction of fibers as G max. So anterior part of the flap is taken from the tensor fascia lata. Now you have two parts of the flap, the anterior part of the flap along with the attachment of TFL distally, and the posterior part of the G max flap with the part of TFL. And that those facial parts are tightly sutured to a flap. A small bony ridge is raised from the from the greater trochanter, and under them are then sutured in a sequential manner. So first comes the posterior flap, and over that comes the anterior flap, and they are sutured under the bone in a special suture technique that we'll just try and elicit along with the vastus lateralis in 15 degree of abduction, so that they restore some abductor function. Apart from restoring abductor function to a grade of about 2+ or 3.5 as documented in many studies, it also decreases the dead space, prevents hematoma formation, gets a pseudocapsule around the hip, which in long term functions as stability on the posterior side, especially to augment the stability. Now, this is the technique given by Whiteside in his very good paper in Core, and I would suggest everybody read that. It's a doable thing. You don't need to invite a plastic surgeon on the table. We can do it ourselves. So you can see that the anterior flap comes as a triangular piece along with the part of the fascia lata. The posterior part, which is the A, which we showed here, this is the posterior flap. This comes with a part of the facial lata. This goes first, the anterior flap comes over it under a bony ridge of bone of the greater trochanter, and they are all sutured together with ethibond or a non-absorbable suture, strong suture along with the vastus lateralis. This is the patient, young patient, at about 1.5 year follow-up. He has got a negative Trendelenburg Berg. Ideally, I should be demonstrating EMG study to show that this muscle really works. And this soft tissue flap is just not a cosmetic reconstruction, but a functional reconstruction. And there are certain studies which show on EMG. I'm waiting for a 2.5, 3 year follow-up when we can really do an EMG to demonstrate that these flaps work. We don't have a large series, we have few cases, but I feel that in younger patients, if we reconstruct the soft tissues as well, this will augment the soft tissue reconstruction, the posterior capsule, and will prevent instability rather than just relying on a dual mobility cup. Thank you very much.
Thanks, Dr. Anup, for giving us an excellent insight into reconstruction of this abductor deficiency. And hopefully, we all will be able to use the same technique in our cases if we have some. Dr. Harish, would you like to comment upon anything you would like to add? Anyone?
I think it is very important to look at the soft tissue. That is very, very important, because that is an important factor in preventing dislocation. And what Anup did was quite ideal. I haven't done similar thing before, but it's a good technique to use sometime in future. And I would probably try to use it.
I've used only a dual mobility cup with the HO cases, but I've never had a dislocation. But I think it's an excellent technique to augment the abductors. That's excellent.
Anup, I think it's a wonderfully demonstrated case. Do you keep these patients in the what's the mobilization protocol for these patients?
Correct. That's a great question. Yeah, I should have spoken about that. So they are in abduction brace. So you need to keep them in about 10 to 15 degree abduction, and we mobilize them a little later at about 3 weeks, not immediately. And they are in abduction brace for about 6 weeks, and then they go full weight bearing. So you need to protect your flap in abduction till it heals nicely.
Very good.
There is your comment, suggestions.
A couple of comments. I think the first comment is we've had a couple of these cases where the sciatic nerve is actually going through the bone, so you really have to get your imaging right and be ready to do some pretty hairy dissection all the way through. So this is a not uncommon scenario post head or spinal injury. I mean, you've done a great job here with the soft tissue reconstruction. I have to say, making people Trendelenburg negative is not something we've succeeded to do with this technique. We have done it. I think it's nice to cover the hip, and any function there is better than no function, but it's tough to get them Trendelenburg negative. So very well done for doing it, because Leo's been selling this for years, but most of us have struggled to reproduce it to the same level. So well done.
Thank you. Deepak, any experience on this?
No, I don't have any experience on white sites, but this is a beautiful demonstration. I've seen one case before, but again, I've never seen a Trendelenburg negative, as just Professor Haddad said. Great stuff, I have to say. And again, the importance of soft tissues in the management of hip replacement and prevention of instability. Very, very important. Well done.
Thank you. Thank you. I think we are running short of time. Is there no more questions? Anup, would you mind stop sharing your screen?
Yeah, sorry. Yeah. Oops, where is my cursor?
Of this wonderful discussion on instability in total hip. Any last moment thoughts anyone has to share?
I think we are going beyond the time. So before we conclude this beautiful session, can I have some concluding remarks from Rinal?
I think I thank everyone for being there. All the faculty, Dr. Faris, Dr. Berry, Dr. Su, Dr. Deepak, Dr. Harish, Dr. Sharma, Dr. Pradeep Bhosle, Dr. Anup, and all IA member executive committee who were there. It's been an excellent discussion and presentation, and obviously instability is something which can be a surgeon's nightmare. And you've given excellent insights on how to manage them and prevent the instability. And it was an excellent discussion on all aspects, including dual mobility and constrained liners, and abductor insufficiency managed with soft tissue repair, plus the recurrent dislocation. So I think we have had excellent faculty giving their thoughts, and we should all try and plan, and avoid at the first go any kind of instability. That's it. And I thank everyone, and I thank Deputy Johnson & Johnson, Deputy Synthesis for supporting us for this IAA webinar. Thank you, everyone. Dr. Mohanty, any?
Yeah, Professor Faris, your concluding remarks, please.
I think it's been a very enjoyable session on a very important subject that's close to the heart of every orthopedic surgeon. You've done a wonderful job of covering everything from how to think about it and prevent it, all the way through to horribly complex cases where you've done some beautiful salvage. So I think it'll be a joy for people to watch. So thank you for including all of us on behalf of Ed and Dan as well, who couldn't stay till the end. A big thank you from your international guests, and we all look forward to being with you in person next time.
Thank you. Deepak, your concluding remarks, please.
Thank you, Shubhranshu. I think it was a great session, very good talks, some really challenging cases that were demonstrated by the Indian faculty as well, and really great to see the different aspect of management of hip instability. What you see in India is something which is different than what we come across here in UK. Really good from that perspective. Very important topic and very well covered and very well chaired by all of you. Thank you very much.
Thank you. On behalf of Indian Arthroplasty Association, we convey our gratitude to our guest speakers, Professor Faris Sadat from UK, Dr. Daniel Berry from USA, Dr. Edwin Chu from USA, and Mr. Deepak Khelekar from UK as well. And we also thankful to all our faculty, Indian faculty, who has presented beautiful and difficult, interesting cases today. And I also thank Dr. Minan Sharma for taking all the pains to organize this webinar, which is long awaited and a difficult, problem to address too. And we thank Deputy Synthesis for their academic support for this webinar. And our next webinar, number 15, will be Reconstruction Strategies in Revision Total Knee Replacement. And it will be on the 3rd Tuesday of April, that is 20th April 2021. Evening, and the convener will be none other than Dr. Anup Jurani himself, who is the Director of Orthopedics at Fortis Escorts Hospital in Jaipur, India. Please log into our YouTube channel and Facebook channel. And the evening, we'll give you the detailed program later on. And initially, there are some hitches about live transmission on YouTube. I apologize for that. There are some technical hitches, but we'll be putting up the entire webinar in our YouTube channel, IAA YouTube channel. All of you can view from beginning to end later on. I thank you all for attending, those who are attending from the YouTube and Facebook, and have a nice evening. And good night to you all.
Thank you very much.
Thank you, everyone. Good night.